All right, pulmonary embolism is the same as chapter 36. Remember DBT, third semester? So that was the same DBT that traveled and then now became a pulmonary embolus. However, it doesn't have to start as a deep vein thrombus. It can also start right in the either in a PICC line or a flutter, or in the case of severe exacerbation of heart failure, for instance. So there are different ways blood can flow, but the same. So the problem here in the PE is there's a blood clot. It could be one or more blood clots that ended up in one or more parts of the pulmonary artery. So to illustrate, so if this is your heart, and this is the right ventricle. So your pulmonary artery arises from the right ventricle, correct? And you have the right and the left lung. So this divides into the right and left pulmonary arteries. Okay. All right, so let's say the pulmonary embolus ended up on the left side. So it's a tiny clot. This could have been from a DBT that ended up here, or maybe it formed right here in the right atrium or the right ventricle. And then the clot finally blocked one tiny portion of the artery. Okay, so let's say there are multiple. So let's say 1, 2, and 3. So there is a forward flow problem here. So this blood that went there to the lung, no problem. Let's say there's no problem on the right lung. So this is the right, this is the left. The problem ended up on the left lung. So you have one or more pulmonary emboli there. If this had happened in a coronary artery, which we'll discuss in chapter 38, this would be called a myocardial infarction. If it occurred in a cerebral artery, which we just concluded, this would have been called a cerebrovascular accident or a stroke or a TIA. Why isn't it called pulmonary infarction in the case of a pulmonary embolus? Because this is exactly what's going on. You have one or more blood clots blocking the pulmonary arteries, resulting in a mismatch. So there will be a mismatch here between ventilation and perfusion because the lungs have no problem ventilating. The airway is open, so you have the main bronchus here dividing into the right and left. So this is the bronchus. No problem with ventilation. It's really the perfusion that's the problem part because one or more pulmonary arteries are blocked here. Now, again, the question is, why isn't it called a pulmonary infarction? And we call it myocardial infarction if these clots ended up in a coronary artery, or we call it a stroke if they had ended up in the brain, or we call it acute arterial ischemia in a peripheral artery. Why isn't this called a pulmonary infarction? Anybody?
Maybe
the tissue doesn't die.
So our blood clots races, they only choose the heart, the brain, and the peripheral arteries and not the lungs?
In the lungs, there is still a ventilation. So that's why it's not completely dead, the tissues.
Yeah, I agree. There's ventilation, but there are clots here But why isn't it called pulmonary infarction? Why is it only called pulmonary embolism? Why don't the lungs, the lung tissues die here? Because let's face it, there's no blood flow going to these sections, whatever sections this part here is perfusing or supposed to perfuse. Why don't the lung tissues die?
Does that have to do with the other lobes?
Oops, yeah.
Yeah, we have other lobes, but this lobe in particular. So there are only 2 lobes on the left lung, right? And we have 3 on the right. So let's say this is the upper lobe that is obstructed. Why doesn't the upper lobe die?
The lower lobe is compensating for it?
Well, let's say there's blood flow, no problem in the lower lobe. This lobe particularly did not receive blood flow because the blood clots are obstructing those pulmonary arteries, those pulmonary branches. Why isn't it called a pulmonary infarction? Why don't the tissues die? All that will happen here is there will be increased pressure because afterload here increases. Therefore, resistance increases in the pulmonary circulation. That will increase the workload on the right side, which will show later when we get to the signs and symptoms. There will be right ventricular dysfunction here in pulmonary embolism. But the lung tissue technically doesn't die. Have you ever thought about that?
I'm thinking maybe it's the fluid that in the lung, it will actually helps not to die the tissues.
Say again, Miss Lama, one more time.
I'm just guessing. Maybe it's because of the fluids in the lung that like a synovial fluid, and this actually gives the lung tissues to not die.
Yeah, well, there will be pulmonary edema here also. You look on the key features, there will be pulmonary edema because there is congestion here. Because if you block these arteries, then there will be congestion of blood here, leading to, again, decreased forward flow here. So some blood that's supposed to go to the right lung cannot because you are blocking major arteries. No problem on the right. There will be continued gas exchange and perfusion on the right lung. But here in our example, there is no perfusion here. So the right ventricle will suffer, which will be manifested in the features later. So you'll see right ventricular dysfunction. But why don't these guys here die? If you read the pathophysiology, none of them die really. I mean, the patient will die, but the lung tissue itself won't. Meaning there is enough ventilation, it's the perfusion that's the problem. Okay, instead of 1:1, you'll be down to, I don't know, 1 is to less than 0.2 maybe or less, because it really depends on how many pulmonary arteries are affected. Okay, so the answer is there is dual circulation in the lungs. Unlike you know how the blood, so this is the superior vena cava and inferior vena cava, blood enters the heart, correct? Is that blood entering the heart perfusing the heart?
No.
No.
No, right? It has to wait. The heart has to wait until the blood comes out of the aorta. And then you have the coronary sinuses here. The coronary arteries branch out of the aorta, correct? So as blood goes out here during diastole, blood falls back and then blood fills the coronary sinuses, the coronary arteries, and then the heart gets perfusion. It's the same exact concept here. So the blood entering through the pulmonary arteries technically are not perfusing the lungs. What's perfusing the lung is another branch from the aorta. So you have the 3 here, so you have the coronary artery, subclavian. Down the thoracic arc, is the bronchial artery. The bronchial artery perfuses the right and left lungs. So in this anatomy, this unique anatomy of the pulmonary circulation prevents pulmonary infarction. It's almost impossible. I'm saying almost because there is a chance that the bronchial arteries can be blocked, but that's a very small chance because again, there's dual circulation here. The lungs can perfuse a little bit via the pulmonary arteries, but majority of its perfusion really is via the bronchial arteries, okay, which arises from the aorta, not from the pulmonary arteries. You understand now? So that's why this is not pulmonary infarction. It's only pulmonary embolism. But it can still kill the patient, of course. So here, there is a shunting effect here. What kills the patient is there will be you remember in peds wherein you had shunting in ventral septal defect or tetralogy of Fallot, wherein there was deoxygenated blood circulating in the system because of the congenital defect.
Mhm.
Yeah, so it'll be the same here. Although there is no anatomical defect here, but the blood went to the arteries, but did not get any oxygen in return because of blockage. So as a result, some of the blood returned to the left side of the heart, not carrying any oxygen. So that's why here in this illustration here, this is normal ventilation perfusion, meaning every time blood gets to the lungs, they're supposed to get oxygen back. So they bring oxygen back when they return to the left side. Here, there is none. Okay, so they go there, but then they cannot bring oxygen back. So therefore, there is less oxygenation for all body tissues as a result. We have different types of pulmonary embolism. Clots are not the only cause. We also have other particulate matter, namely solid objects, let's say a piece of a central line, for instance. It could be fat emboli, it could be air emboli, right? There are different types of debris or matter that can become emboli. But for purposes of discussion, chapter 32 will only talk about a PE caused by a blood clot. So let's review the Bierko's triad. There were 3, correct? In chapter 36. So we had 3 conditions that lead to a blood clot formation. So we have hypercoagulability, we have venous stasis, and we have endothelial injury. So all these 3 conditions lead to clot formation. Right, so examples here are endothelial injury. This is the major. We have vessel injury. So every time a vessel is injured, so give me examples wherein your vessels are injured. It could be a capillary, an artery, or a vein. Give me examples.
Stab wound.
Sorry? Hello? What was that?
Like a stab in injury or a paper cut.
Okay, so let's say a paper cut, a needle prick, for instance, you're checking your patient's blood sugar, you're drawing blood, so you are injuring a vessel. So number one cause there is surgery. We also have endothelial injury in trauma.
You break a bone?
Right, yeah, so trauma could be usually major trauma, or it doesn't have to be major actually. So you cut yourself, so there are vessel injuries there. Or any other procedures. Or in OB, for instance, you had abruptio placenta, you had placenta previa. Okay, so you have several bleeding episodes there. In chapter 40 also, you talked about bleeding conditions, HIT, ITP, TTP. So you have a lot of bleeding problems there. Venous stasis is any condition that results from immobility. Or it could also be from obesity. It could also be from heart failure, dysrhythmias, namely AFib, A-flutter. Hypercoagulable conditions, examples are people taking oral contraceptive pills, for instance, or you're on steroids. Cancer, right? And then many others. These are all found in chapter 36 because that's where the Bierko's triad was discussed. So the same conditions that led to the formation of a deep vein thrombus, the same things that will lead to the formation of a pulmonary embolus as far as clots are concerned, right? So therefore, these are the conditions that for any patient, therefore, that have the Bierko's triad are the ones you target for prevention. And every patient, right, we do the Dbt Risk Assessment. Every admitted patient is screened for their DVT risk. If they didn't have one during admission, then they probably will. So the DVT risk assessment is done every day, every shift, because you constantly see, because let's say Sean comes in for an elective knee replacement. So Sean came in walking. He went into the hospital, walked in, and signed in, in admission, and then went to the floor. So he's prepped for surgery the next day. So before that, he was walking. He was constantly walking. But then after surgery, will he be walking as frequently?
No.
No. So therefore, his risk changes, okay, depending on what we did or how far along the care we are. So let's say 6 months from now, after Sean has had therapy, for instance, so as his mobility increases, will his risk factors remain the same? Will they be the same?
No.
No.
Okay, so therefore, this is why you still check your DBT risk assessment every shift. Okay, it doesn't stop. Any questions? Somebody's absent. Who's missing here? I'll check it out later. Let's check it. Any questions so far?
No.
All right, so you have a summary here of some of the major risk factors leading to the formation of blood clots. So here, this is under venous stasis. This one's venous stasis. This one is hypercoagulable condition, having a central line, especially PICC lines. You learned that in chapter 13, that PICC lines are notorious for forming blood clots. Surgery falls under endothelial injury. Obesity falls under venous stasis because the weight of the person, of the patient, will cause venous return to be slow, so that will cause venous stasis. Advancing age, also venous stasis. And conditions that increase blood clotting, I mentioned cancer, I mentioned people taking long-term steroids, or those who are on oral contraceptive pills, also people who smoke, for instance, or if you have a history of thromboembolism, meaning you had a risk before, they usually do not go away, right? So these are some more examples here. And as already mentioned earlier, blood clots are not the only cause of a pulmonary embolus. They can be fat, oil, air, tumor, amniotic fluid, fecal debris, foreign objects. Okay. One of the complications of a PE are the following, which are also discussed in chapter 32. They include respiratory failure as well as ARDS. And later, when we get to shock, one of the causes of obstructive shock is also a pulmonary embolism. So these are all related to each other. Don't worry, we will discuss all of them. Let's discuss first with prevention, because the mortality of PE, depending on the category, is quite high. It's between 62% or higher, depending again on the category. So it has a high mortality. In fact, most of the causes of death, when you walk into your patient's room and you find them dead, this usually happens in med-surg floors wherein there is no telemetry, meaning they're not hooked up to a monitor, so you have no idea whether they're alive or not unless you actually go and make rounds. And sometimes, nurses don't make rounds, so by morning you find your patient already stiff, right? So chances are, in those scenarios wherein you walk in and the patient's already dead, so the usual cause of death was usually a PE. So here are your preventions. Please read them on your own. So these, if you look at them, they're trying to eliminate the Bierko's triad. They're trying to relieve immobility, decrease their chance of forming blood clot by eliminating venous stasis, by keeping blood moving, right? So number one here, intervention is to ambulate the patient as soon as possible. If they can't ambulate yet, at least get the blood moving by putting on stockings or pneumatic compression devices, for instance, SCDs, PCDs. If not enough, then the doctor will order anticoagulants. Again, these here will prevent circulation or decrease circulation, so therefore avoid them. And whenever you receive orders to elevate the legs, such as people in heart failure, never put the pillow directly under the knee. Those pillows must be under the calf only, not under the knee, so as not to impede circulation from the popliteal arteries and popliteal veins.
Professor, pillow not under the knee, is it because of the infection or respiratory infection?
No, you are obstructing the popliteal arteries and veins.
Oh.
Yeah, so only put the pillows under the calf. And Valsalva maneuvers will increase intrathoracic pressure, which will decrease venous return. You remember the explanation here, Valsalva maneuver. This was discussed in chapter 36, third semester. So if you're bearing down, for instance, or holding your breath, these will, of course, cause you to inhale deeply and then hold your breath. And when you do that, of course, the lungs, the left and right lungs here are hyperinflated for an extended period of time. Now, remember that the heart and the lungs share the same thoracic cavity. So the mediastinum here, if you hold your breath, is really compressed. It will compress the heart, compressing the large vessels, namely the superior and the inferior vena cava, causing less venous return. And as a result, of course, blood will tend to pool because there's now congestion in the upper and lower parts of the body, leading to possible blood clot formation. Smoking cessation is last. The explanation here are on the next two paragraphs. So chart 32-1 is explained in these two paragraphs right here. All right, so let's do signs and symptoms now. Chart 32-2 are key features, but they're not really specific because not all patients will present the same way. It really depends on the category. You can read 32-2, but let me just explain why these occur. So the dyspnea here and the chest pain and the feeling of impending doom, no severe anxiety, these are all as a result of hypoxia, meaning if oxygen throughout the body drops, remember this will now serve as a trigger for the autonomic nervous system. So there will be automatic sympathetic nervous system response causing the tachycardia. And the tachycardia here, remember, will increase oxygen consumption and oxygen demand on the heart, which again was the problem in the first place, because now we have one or more pulmonary arteries blocked by blood clots. So therefore gas exchange is impaired. And now we have a ventilation perfusion mismatch in the first place. And then the body now responds in a way that will cause more oxygen demand and consumption. So very ineffective, but there's nothing we can do. That's how the body responds. So that's why you have these symptoms here. The coughing and the hemoptysis, these are now as a result of the pulmonary edema because again, congestion occurs in the pulmonary circulation in the affected lung, which will now increase again workload of the right side of the heart, which will now result in your extra heart sounds. So there is now congestion on the right side that will lead to right ventricular failure, resulting in these extra sounds, and that will lead to more tachycardia. These here are later signs, especially the petechia and the low-grade fever. This is only for massive PE. I'll show you in the next table. And of course, there will be decreased oxygen saturation. Now, there will be cardiac symptoms here. So if you remember in COPD, the patient in long-term COPD developed cor pulmonale, right? If you remember. So people with long-standing COPD will have pulmonary hypertension. As a result, the right side will fail. So same thing happens here. There is now a reduced forward blood flow, as I drew on the whiteboard earlier. Now this results from the acute pulmonary hypertension. And this again will cause systemic hypotension because if you imagine, there is now less blood getting to at least one lung because of the obstruction, right, caused by the pulmonary emboli. Now that means only circulation from the other lung will return to the left side. So let's say that's only half. So therefore you only have half of the blood that is supposed to enter the left side. So therefore you only have half the cardiac output coming out of the aorta. So that will result in hypotension.
Are you there, Professor?
Professor, we can't see you.
Hello?
Hello, guys. What was the last thing you heard? Where did you lose me?
Hypertension.
Systemic hypertension.
Oh, that far? Okay. Okay. So, where is that? Okay, so we were here. You heard me talk about this part. Yes or no?
Yes, Professor.
All right. So, like I said, if you have more than one,
So you're not sharing your screen?
okay. All right, so let's go back here. So if this is the heart, these are the lungs, and this is a pulmonary artery. So let's say just this left pulmonary arteries are blocked. And let's say on the right side, no problem. So when they return via the pulmonary veins, you have normal return from the right side. However, from the left side, which is now affected, because there is reduced forward flow here, because the blood pumped by the right side here toward the left lung is decreased, correct? Because you have obstruction here. So therefore, less blood going there. So let's say this one is free. So only this one is able to perfuse here and therefore is able to return via the pulmonary veins, whereas there's no problem here. So therefore, you have normal venous return from the right lung, but you have less coming from the left. So therefore, reduce forward blood flow, what will happen to your cardiac output, Mr. Joseph?
I would say it's reduced.
Okay, so reduce cardiac output. So that's what that statement there is referring to. So there is therefore reduce forward blood flow because of that pulmonary hypertension. So the pulmonary hypertension here results from those blood clots because they obstructed one or more pulmonary branches, pulmonary artery branches. So therefore, it will cause increased afterload, increased resistance, at least for the right ventricle. So that will cause pulmonary hypertension and therefore reduce forward blood flow. Please read this. These are emergency findings. This will be present in a massive PE, which will be in the next table shortly. Now, I was saying earlier before we got cut off that if you look at chart 32-2, Mr. Espinosa, are these exclusively found in a PE?
No, they seem similar to like symptoms of an MI.
Also in heart failure, correct?
Heart failure, yeah.
Or somebody who's having acute COPD exacerbation also, or someone who has a pneumothorax even. So they're not exclusively found in the PE. So therefore, will you expect the doctor to order only one test?
No.
No. So look at the number of tests he's going to order. So the first is we draw ABG. So that's arterial blood. Venous blood, we will have these tests right here. So let's look at them one by one. Because again, a patient having a heart attack, having heart failure, having a dysrhythmia, having COPD, exacerbation, having a a chest trauma, pneumothorax, for instance, will show exactly the same. So therefore, to make a fast diagnosis, we will draw everything. So number one, metabolic panel. So that will give us our chemistry to see if there are metabolic imbalances, for instance, causing these symptoms. So we're looking at your kidneys, for instance, so kidney function, liver function, electrolyte panel, and then for troponin, of course, that's specific to a heart attack. And then we had BNP, which was in chapter 35. This one was exclusively released by the ventricles, right? From the stretching, you remember in heart failure. So BNP is diagnostic for heart failure, meaning there's no other tissue in the body that produces BNP. So if it's high, then it's heart failure.
Isn't that also in like heart attacks too? They like measure that to see if we
For troponin,
okay.
is specific for cardiac tissue injury. BNP is drawn because, of course, after a heart attack, the patient may go into heart failure. And then finally, we have a D-dimer. So D-dimer is a fibrin split product. This is a result of fibrinolysis. Now, before we go any further, let's review your clotting cascade. Can you see the YouTube video?
Yes.
Yes.
And you can hear audio also?
Mm-hmm.
At the site of vessel injury, the first platelets arrive to start sealing the wound. Simultaneously, the coagulation cascade with its various coagulation factors is activated. This involves two pathways, the extrinsic and the intrinsic pathway.
Right, so first shown here, this is the extrinsic pathway. So if you recall the last time you had a paper cut, you had bleeding, but then after a few seconds, it stopped. But then after you washed your hands, or if you remove pressure, 1 minute later, it started bleeding again. All right, because it was the clot that was formed initially was a unstable clot, meaning nothing was holding that blood clot together, meaning you have red blood cells and platelets in there, but nothing is holding the whole operation together. It's unstable. And then, so therefore you have to wait a few more minutes later before it will stop bleeding altogether. So you have to wait for the intrinsic pathway to finish with clot formation.
Extrinsic activation begins with now exposed molecules of the vessel wall, such as tissue factor, which forms a complex with factor 7. Finally leading to the activation of factor 10.
Okay, so this is the end of the extrinsic pathway. So every vessel that is injured, whether you prick it with a needle to check your blood sugar, you had surgery, every single capillary, artery, or vein that is injured. So this is referring to the endothelial injury. So they all release tissue factor, and tissue factor will get the clotting cascade in the both extrinsic and the intrinsic pathway started. So these, you can say, are the trigger. Okay, so they will stimulate the clotting cascade.
This factor 10A is the point at which the extrinsic and the intrinsic pathways of the coagulation cascade meet.
Okay, so the next part here, this is now the intrinsic pathway, which takes a little bit longer. So several minutes later, several minutes to finish That's why bleeding will continue until this part here is completed.
The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor 10. Since the two pathways merge at the level of factor 10A, this factor has a pivotal role in the coagulation cascade. Further down the cascade, factor 10A in combination with
All right, so here's now prothrombin. So 5A and 10A will activate each other, and then now will break up prothrombin, convert it to thrombin. So this is where heparin comes in. We also have drugs under the new novel oral anticoagulants, namely Xarelto, which is rivaroxaban. We have apixaban. We have dabigatran, etc. They are under 10A, so they are 10A inhibitors. And then we have heparin, which is the oldest, one of the oldest drugs. Heparin stops this part right here because heparin is a thrombin inhibitor. So by stopping thrombin from being formed, it will therefore stop the clot formation. Therefore, clotting is stopped. However, this is only stopping future clot formation, or it will prevent further activation of platelets. Therefore, if you have a clot, the clot will remain the same size because once the clot is already formed, you give heparin, no other clot will be formed moving forward.
with 5A activates thrombin and induces the so-called thrombin burst. One molecule of factor 10A can catalyze the formation of 1,000 molecules of thrombin.
All right, so if you have heparin on board now, this whole step here is not going to happen. So no thrombin activation, no fibrin formation, right? So therefore, no blood clots form.
These large amounts of thrombin cause the further activation of platelets and the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug in an arterial clot and holds together the red blood cells in a venous clot.
All right, so now voila, you have a blood clot. So you have fibrin now holding the whole thing together. This now becomes more stable. So therefore, no matter how you touch the paper cut that you have, it will not bleed anymore because you have a permanent blood clot there. So it will not bleed anymore. However, right after this step is done, the next step is now fibrinolysis. The body will start to break this down. This will take several days to a few weeks though. So it will take time for the body to dissolve this blood clot. And it also depends how many blood clots are we talking about here.
Oh my God.
All right, so this will, the next step here, this will be broken down by the body. And one of those products is what we call D-dimer. All right, any questions so far?
So I was just curious, what role does aspirin play in this? Is aspirin doing the same thing as
aspirin is not an anticoagulant. So our anticoagulants are only heparin, warfarin, low molecular weight heparin. Those are anticoagulants. Platelet and Plavix are antiplatelets. So they only act on the platelets. They have no effect on the clotting factors. As you can see, our anticoagulants affect the clotting factors at various stages of the coagulation cascade.
Okay.
All right, okay. So let's go back here. So that's why it makes D-dimer very important. So D-dimer was used in chapter 36 to help diagnose DBT, and then we also have D-dimer again used to diagnose, help diagnose a PE. Now, the D-dimer here is not used to exclusively prove the presence of a PE or a DVT, right? So as you remember in chapter 36, the only way we diagnose or the doctor makes a diagnosis is one, in the case of a DVT, he orders a Doppler ultrasound. We have to literally see the blood clot. Same thing here. If you suspect a PE, but then again, you have to start with a blood test first because you have to isolate your diagnosis. That way you're not wasting money ordering all these tests without doing a process of elimination. So after the stat blood test came back positive for the dimer, your BNP was negative, troponin was negative, so all our blood tests are pointing towards a blood clot, either a DVT and or a PE. Then the doctor orders the CAT scan. So the CT angio here is the gold standard. We have to literally find the blood clot or the blood clots. Now, this is of course involving a dye, so therefore your pre-procedure check is to check for allergies. So if the patient is clear from allergies, we send the patient to the test. However, if the patient's allergic to the dye or the patient has any evidence of kidney injury, then of course that is a contraindication for a dye. Now the doctor has one more alternative, which is a BQ scan. The BQ scan is done in nuclear medicine. So instead of putting a dye and then through the IV and then taking a picture, wherein whichever pulmonary artery parts that doesn't show up with the dye, then that means there is the obstruction. If we can't do that, then we'll have the patient inhale a radioactive gas instead. So we'll just go the other way. So we still take a picture under nuclear medicine. If whichever parts of the lung, whichever lobes of the lung does not show up with the dye, that means those are the parts that have no ventilation or perfusion. That's where the mismatch are, and then you can still see the blood clot right there. Management. So number one management is oxygen. So you have chart 32-3. These are general managements, okay? So chart 32-3 will be for every PE patient, regardless of the type. Meaning these are the common interventions. Right? I'll let you read those on your own. We go specific now. So table 32-1 is the specific treatment depending on the category. So we have 3 categories of PEs. We have massive, we have submassive, and then we have the low risk PE. Massive PE is referring to a large number and size of blood clots. Look at the mortality, 65%. Now, imagine large and multiple blood clots here blocking one or more pulmonary arteries. So can you imagine the amount of pulmonary hypertension that results here? The amount of forward blood flow decrease, the amount of pulmonary hypertension that is occurring. So that's why the patient will go into shock. Okay, so when we go to chapter 37, this is one of the causes of obstructive shock. As a result, because the patient goes into an acute right ventricular failure here, patient could go into cardiac arrest. So there is now a new severe bradycardia. I already mentioned shock. And of course, this patient will go into respiratory failure at the same time. So that's why your interventions, of course, is CPR. And then I'll discuss the inotropic drugs in chapter 38 because I don't want to discuss it now and then discuss it again later because technically this is not for the PE technically, it's for the resulting complications, meaning the inotropic and vasopressors here are to treat the cardiac arrest, to treat shock that resulted from the PE. So the PE itself is really just treated with anticoagulants and TPA. We already finished why we give a TPA. This is of course to dissolve the clot, because here in the massive PE, can we wait for the body to naturally dissolve the blood clots on its own?
No.
No, we don't have time. This patient will die in the next few minutes unless we dissolve the clot using TPA. So the patient will receive two here, so TPA and heparin. I know it sounds dangerous because both of these drugs are high risk for bleeding, but we have no choice, meaning we have to dissolve the clot, plus we have to prevent new clots from forming at the same time. Submassive PE. So here, there's really no need to give a thrombolytic because look at the blood pressure. Patient's blood pressure is normal. However, there is right ventricular dysfunction. So they may show failure as well as some dysrhythmias. I won't test this part yet because we'll have to wait until chapter 34 before we do dysrhythmias. So that part will not be tested yet, at least for the quiz for next week. There will be elevated BNP or troponin here to some extent, again because of right ventricular hypertrophy and right ventricular failure that will result from a submassive type of PE. So here, don't forget, you can disregard thrombolytics because I've never really seen them use thrombolytics for submassive because again, there's really no need to put the patient at risk for bleeding when your blood pressure is normal, right? There is cardiac output here, so I don't think they'll risk giving thrombolytics. However, the patient will receive heparin and then warfarin at the same time because the patient has to be discharged eventually. And then finally, low risk PE, very low mortality. Most of these patients are not even admitted to the hospital. So they'll just be kept in the ER and then discharged home on either low molecular weight heparin or novel oral anticoagulants. Now, if you remember in chapter 36, LMWH, the patient can be safely sent home on this because there's really no need to monitor blood work because although this is heparin, PTT is not necessarily really monitored because the dose is weight-based. So let's say the patient weighs 60 kilograms, so the dosing is 0.1 milligram per kilogram. So the patient goes home on 60 milligrams of Lovenox. Even if the PTT changes, the dose will not change anyway. Does that make sense? Because the patient is still 60 kilograms. So no matter what the PTT says, do we change the dose?
No.
No, because the patient's weight didn't change. Okay, so that's the reason why there's no need to monitor PTT for LMWH in the case of low risk PE. And it was also the same in DBT also. And these drugs are the most convenient because they have no blood work needed, they have no diet restrictions. All right, so we already did the oxygen therapy in chart 32-3. Next is when can the patient be discharged? All right, so we always start with heparin because if you look at the clotting cascade animation, the fastest way you can anticoagulate somebody is using heparin by stopping thrombin activation. So the moment you give the injection either IV or sub-Q, the patient's prothrombin is not going to be converted to thrombin. Therefore, no further clot formation as soon as you give it. However, you have to maintain the drug though because unfractionated heparin has a low half-life. That's why it is given in a continuous infusion. Now, don't confuse this with the subcutaneous injection because that one is given as a prophylactic dose, not to treat a PE or a DVT. So our goal here is to make the PTT 1.5 to 2.5 times the normal. Then we won't do alteplase anymore unless it's a massive PE. So here is the protocol. So we give heparin today. Warfarin is also given today at the same time. Now, if you look at the clotting cascade, it made no mention of vitamin K. Coumadin is a vitamin K antagonist. This one is only going to affect 4 types of clotting factors, which are dependent on vitamin K. So since we need vitamin K in order to produce clotting factors, warfarin has no effect on existing clotting factors. Therefore, when you give warfarin today, it will only affect future formation of clotting factors. It has absolutely no effect on the existing clotting factors already present in the plasma. So that's why it will take about 5 days for the patient to be on heparin or warfarin, sometimes 3 days. The reason is you need immediate anticoagulation until warfarin kicks in, until our INR reaches 2 to 3. All right, until then, the patient will receive both heparin and warfarin. Once we reach INR of 2 to 3, we can then stop the heparin and then discharge the patient. Questions so far?
Yes.
Okay, go ahead.
Professor, you said warfarin will not affect the present coagulation. Present bleeding. So what about, so we have to give Coumadin for that to solve the problem at present? To make the blood...
Warfarin is Coumadin.
Warfarin and the Coumadin is same?
Yeah, warfarin is the generic.
Oh, okay. So that means we can use warfarin to solve the problem, right?
That's what we've been talking about. So you need to discharge this patient eventually, right?
Yeah.
That's why we have to discharge them with warfarin. But you need immediate anticoagulation now. So that's why all patients receive heparin first.
Mm-hmm.
Then you can start warfarin also on the same day. You don't have to wait later. You start it today. However, the patient will be on both heparin and warfarin for about 5 days because the clotting factors, like I said, affected by warfarin is only for future clotting factor formation. It has no effect on the existing clotting factors already in the plasma. Usually, clotting factors are eliminated by the body around 5 days. That explains why that there is an overlap here of about 5 days, sometimes 3 days if we're lucky. Does that
So, yes, so then if the patient is at hospital before discharge, so if there's a clotting problem, so we can give heparin first, right? That will solve the problem quickly.
Patient will be on both. Again, so you're my patient. You have a DVT, you have a PE. You will get heparin today, infusion. You will also receive warfarin the same day. You will have that same therapy for about 3 to 5 days because you need immediate anticoagulation. Heparin provides that, but we cannot keep you in the hospital forever. We have to send you home. You can only be on oral anticoagulants. That's where warfarin comes in. Because warfarin takes a while before it works because, again, it does not affect existing clotting factors. It will only affect future formation of clotting factors. So until the body eliminates the existing clotting factors, which takes about 5 days, the patient will have to be on both heparin and warfarin until that happens.
Thank you so much.
All right, until our INR reaches 2 to 3. All right, so these are all anticoagulants. So chart 32-4 are your nursing responsibilities. Please read them on your own, including the blood bleeding times that will have to be monitored, as well as the antidote. So for heparin, you monitor PTT, you have protamine sulfate as your antidote. Vitamin K antagonist, which is warfarin, you monitor PT-INR, and you also have vitamin K ready, which is your antidote. And because that's your antidote, so you have to avoid these foods because they are high in vitamin K, which is the antidote. Now, let me emphasize, this is not to be eliminated, okay? It just says here, they will be rendering warfarin ineffective if eaten in excess. So does that mean you can't eat these foods?
No,
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 you can eat them, but
not in
lesser,
excess.
right? In lesser amounts. And I'm not doing fibrinolytics anymore because we already did that. And that should, last chart, 32-5. There are some variations here. So for instance, if the patient has a recurrent PE, look here. If the PE is recurrent, meaning this is not the first time the patient had a PE, this is now the second or third, instead of 2 to 3, the INR will have to be 2.5 to 3, or even 3 to 4.5. Right? Because your risk necessarily is higher. So we need your bleeding time to be longer. And that's it.
Professor, I have a question. So basically the range is pretty much 2.5 to 4.5. Like
Well,
the therapeutic range is 2.5 to 3, but if it's recurrent, it's 3.0 to 4.5. So wouldn't that just mean if it's recurrent, it could fall in between 2.5 to 4.5?
Well, for the first time PE, for instance, we want you to be at least 2 to 3. If you remember, DVT was 1.5, right?
Mm-hmm.
So for a PE, we need it higher. So that's 2 to 3. And then if it's, let's say a massive PE, then we go maybe 3 to 3.5. And then for a recurrent PE, it has to be 3.5 to 4.
Okay, thank you.
All right, and the IBC filter was already discussed also in chapter 36, so I'm not repeating that. But it will still be tested. The rest of these interventions are already to treat the cardiac failure that results, so I'm not testing that. So only PE up to this part right here, page 620. Any question? Alrighty then, so I'll send you the recording and I'll also post the grades shortly. All right, see everybody later.
Thank you.
Thank you, Professor.
Thank you.
Thanks,
Thank you.
Professor.